สู่ IAEA Expert Mission Strengthening Optimization in Radiological Practice นะคะอาทิตย์นี้เป็นอาทิตย์ที่9แล้วนะคะที่เราได้มาพบกันเป็น weekly lectures นะคะเกือบจะสุดแล้วนะคะประมาณ 80% ของคอร์สแล้วนะคะแล้วก็อาทิตย์นี้เนี่ยเป็นอาทิตย์ที่เรายังจะมาพูดถึงกันในเรื่องของ DR แล้วก็ CR radiograph นะคะในเรื่องของimaging dose metric แล้วก็ how to set up dose alert level นะคะซึ่งเช่นเคยค่ะเราก็ได้รับเกียรติจาก expert นะคะดร. Sam Brady จาก Cincinnati Children's Hospital ที่ให้เกียรติมาพูดให้เราฟังอีกครั้งในอาทิตย์นี้นะคะ Good evening, Sam. Nice to meet you again, and welcome to week 9 of IAEA Expert Mission, Strengthening Optimization in Radiological Practice. And this week is a week that we're still talking about the DR and the CR in terms of dose metric and also how to set up the dose alert level. So I will give the stage to you to show us how to work on the dose metric and set up the dose alert level.
Thank you, Tanya.
After last week, we're talking about the COVID stuff, and I think that is really helpful. So this week we come back, but it's still related to COVID, right? About like a chest radiograph.
Yeah, so we're going to definitely talk about just radiography, DR, CR in general. So as we did last week, we talked mostly about the image quality and all the various different ways we need to optimize to get good images. Obviously, now we're going to talk about the dose side of things. So, so for our educational goals for today's talk, well, and I should also preface, by now I'm sure you're all used to this, but the first talk in this session, we're going to focus on kind of what are the dose metrics that are unique or specific to DRCR, and then we'll take some questions, and then we'll come back and we're going to talk about how to optimize those dose values and how we use those for quality control and, of course, diagnostic reference levels. All right, so with that introduction, so what are the common dose metrics in DR and CR? All right, there we go. Sorry, it wasn't going forward. So the first one, and I should also say, you're going to find that these are very familiar because we've been talking about fluoroscopy. And when it comes to X-ray producing equipment, fluoroscopy, X-ray, mammography, most of these metrics are the same. They each have some unique values, and we will get to that for diagnostic reference, radiography, DR and CR. But when I say air kerma, you probably recognize that. And so there's going to be air kerma measured in a couple of places for DR. The first is going to be at the detector entrance. So obviously underneath, if you have a fixed room, the table, we're talking about the detector in the table or in the wall bucky. And then we have incident air kerma. This is the value that occurs where normally the body would be. And so if you had someone laying on the table, was assumed they're 30 centimeters thick, then the incident air kerma would be somewhere in that region where the body surface should be. But of course, it's measured without any body there. It's just in air. There's CAP or DAP. We've talked about this. This is very much the same concept as is in fluoroscopy. And then unique to DR and CR are the terms exposure index, or EI, and deviation index, or DI. And so now we're just going to kind of go through these 5, and we're going to talk about how to set them up on your scanner and make some measurements and how to make sure everything is correct. Admittedly, this talk is going to be very technology focused. And so this talk may be more of interest to someone like a medical physicist or maybe a technologist that has to work with the machine. And so maybe the next talk will be a little bit more interesting when it talks about kind of holistically how we apply each of these metrics. So the very first one, and probably one of the most important things we do every time we set up an X-ray machine, is we need to make sure we get the right amount of photons or X-rays at the detector. Now, obviously, there's a patient in the inside that beam, so you got the X-rays coming out of the X-ray tube. They have to pass through our patient. They have to pass through a table or a chest wall Bucky stand cover, and eventually they have to go through the grid, and then they get to the detector. So by the time we go from the tube to the detector, we've lost almost all of our radiation. We've basically lost 99% of our photons. And so we have to make sure that number that gets to the detector is the right value. Here I've listed just a few. I didn't give all of the vendors out there, but these are probably your major ones. And this is how they establish their target air kerma at the detector. And you'll notice that it's not actually the same for everyone. Now the target is the same, and my fault. It should say microgray. I forgot to put the units there. I'll get that fixed before I send it out. So these are 2.5 microgray. That's the target. But look how they each approach this slightly different. GE, for example, would have you set the KV at 80, take the grid out, and then you would add 20 millimeters of aluminum. That 20 millimeters of aluminum will approximate the thickness of a patient. Siemens does 70 kV and 0.6 millimeters of copper. Agafa and Philips have aluminum also, and 70 kV. And Carestream, different kV, different combination phantom or filter, I should say. And then Canon, they use plastic, PMMA. And so you can see here that you really do have to understand which of all your vendors, you have to understand the approach to this. Because what you need to do is you need to set this up. You should be testing this periodically. Most vendors, I can speak to, for example, Philips and Siemens that we have at our institution. Every month, our technologists have to expose the detector without anything in between, so no patient, no phantoms, and they put the filter into the collimator head. They pull the trigger, and the system will calibrate itself. So this is very important. And so here you can just see the 21 millimeter aluminum block, or it could be 20 or 25. It's just that thick aluminum block. This is just for one particular vendor. Here you can see this is the Carestream one, and it's the 0.5 millimeter copper and the 1 millimeter aluminum. So where do we place the ion chamber when we are setting up our exposure and making sure, so we're calibrating our system? Well, obviously, if it's the detector that we're trying to measure the entrance exposure to, we need to set the ion chamber or the solid state detector at the location of where the detector is. So if you have a system that is a film retrofit, so when you pull the Bucky out, you can place a CR plate in here, or a portable or wireless digital system like a DR plate. Well, then what you need to do is you need to create a kind of a cutout. I personally have an old CR plate where I've taken the top off it, and I've taken the CR plate out of it, and it's just an empty cassette that I can put in, because what you need to do is you need to place it inside it so that the positive beam limitators, these limiters, these things right here will lock into place. And obviously those people like the technologists and physicists that know that if there is no cassette in this type of a machine, the system, you can't pull the trigger. You can't actually cause beam on. So you have to do that and place your detector somewhere in the center of the exposure field of view. Now here you can just see this is a setup where this is for a Canon where you got the PMMA or the plastic place on top of it. Here's just another example where this is just actually a tethered, you can see the wire coming off, but this is a portable digital wired fan detector that you can just kind of place anywhere in the room. And so in this case, you could actually place your detector directly on top of it, and you don't have to worry about this kind of a setup. So all machines are slightly different. You just have to know the geometry of your system. So what happens, so what's the difference between using a solid state detector and an ion chamber? Well, the difference is the solid state detectors, most of them have some kind of lead backing, or at least a heavy metal like a tungsten on the back of the, and so the diodes and the detector elements for the solid state detector on the top, and so you orient it facing the X-ray tube or the source, the photons will come in, it'll make a measurement of those incoming photons, but it will not collect any measurement from backscatter off the detector. Whereas if you have an ion chamber, these ion chambers are air equivalent. They're basically full of air. And so any photon that comes in and strikes it from the top will be collected, and some of the photons will go pass through the ion chamber and they'll hit the detector and they'll back scatter and they go back up. And then the ion chamber will measure those back scattered photons. That will obviously increase the exposure. And so if you're trying to calculate and trying to calibrate your system so it'll have, for example, 2.5 microgray, well, this system will give you the most accurate approach. This system, you have to correct for backscatter. If you don't have a solid state detector and all you have is an ion chamber, then you need to measure how much backscatter is available, or not available, is produced with this detector. And the way you would do that, of course, is you make the measurement in this geometry right here, where it's directly on top of the detector, and you'll get a value. Let's say it's 10. Now you take the detector out and you expose it in air. So there's nothing behind it. And then that value, let's say it's 8. Well, now you know your correction value, because you know that 20%, that extra couple of microgray or grays or milligray was based off of just simply the backscattered. So there are ways to use both. You just have to know the limitation. Now there's a couple of things you can do if you want to try to simplify your life. You can use lead sheets, or you can just grab one of the lead aprons that you normally hand to parents or other people, support staff or the X-ray staff that use it when they're in the room when the beam is on. Obviously, these lead aprons or lead blocks will absorb most of the radiation, so there will be very little, if any, backscatter. And the second thing that helps is this will protect your detector. So if you're exposing a rather high attenuating object, so in this case, a solid state detector, if you expose that, the detector will see the picture of that. Will see a picture of that probe, that detector, in the reconstructed image. And if you use a high enough exposure, what will happen is when you take that detector off, that solid state detector off, and then you pull another and you expose again, and you might see a ghost or a latent image of that detector. And now, obviously, you don't want that, because you don't want to see a little square detector in the picture of the next patient that comes and gets x-rayed. So placing lead over the detector is a very good way to protect it from doing all of your physics testing. Now, what happens if you forget, because I've done that a time or two, and you accidentally leave a ghost? So you went through, you did all your tests, at the end of the day, you're cleaning up, and you pulled it and you got everything cleaned up, and you pull a trigger just to make sure everything looks good on a clean, uniform image, and then you see a ghost of your detector. And you go, oh, now to make that system available for patients again, what you have to do then is actually expose the detector, once again, with nothing on it, no detector, no lead blocks, nothing, but you need to manually turn it up, set it to a real high MAS. And what will happen is it'll saturate your detector. All of the little dexels or the pixel values will go to their maximum exposure value. And what that'll do is it'll cause the system to calibrate. And then the calibrate, it'll clean it out. And hopefully it'll clear away the ghost. You might have to do it once or twice. But that's how I've found getting rid of it. So if you do accidentally forget and you leave your detector on there, it's not the end of the world. You can clean that up by just recalibrating, forcing the system to recalibrate. So what do we do if we have a fixed detector system? So previously we talked about a retrofit system where you could pull the bucky out where you would put a CR plate or a wireless DR. Well, if you don't have that, if the digital plate, the DR detector is physically embedded in the table or the wall bucky where you can't actually take them out, how do we still make this measurement to the entrance exposure to the detector? Well, what we can do is the only thing we can do is we place our probe directly on the surface. So either on the wall bucky or you can place it directly on the table. And we do all of the measurements like we normally would. And once again, I would recommend putting lead over it, all that stuff just to keep it safe. But we need one extra piece of information. We need to know how much this table attenuates those photons and how much the wall bucky cover, attenuates the X-rays. So we can do a couple of things. Of course, we can measure it ourselves, or we could just ask the vendor. Most of the time, the vendors know the answer. So how would we measure this ourselves? Well, it's actually pretty simple, right? You have the table here, and all you do is you just move the X-ray tube over here to the point where the table is overhanging the base. So you have space on top to make your measurement and space on the bottom to make your measurement. So you would just make your measurement. You put your probe here. You would measure it, and then you'd move it, and then you'd put the probe underneath the table and measure it. And the ratio or the difference of the ratio of those two exposure values would tell you what the attenuation is of the table. And the same with the detector plate cover. Now the trick with these wall bucky stands is you can't actually slide that. There's no place behind it where there's just air. As you can see, obviously there's grid and detector behind it. But one of the things I do when the service engineers come in to do their preventative maintenance, sometimes annually, sometimes quarterly, depends on your vendor and how often they come by. They'll take those detector covers off and then they'll do their thing, clean, fix, move stuff around. But what I have always done is just asked them before they put the cover back on if I could just make a couple quick measurements. And so I do the exact same thing. I make some measurements on top of the cover and then below the cover, and then I know what the attenuation is of the cover. So you can see here, this is just an example. This is one of my worksheets in my Excel spreadsheet. Here I imaged with 70 kV, a specific MAS. I used a specific filter just so I could set up a beam quality. And that RQA5 we're going to talk about in a couple of slides. So don't worry too much about that. I'll explain in detail what that is. And then you can see here, I get my measurements of the detector under the table and on the top. And then of course the ratio of that gives me a 16% attenuation. And the same with the wall was 14%. So now I know for this system, for one particular room, I know what the attenuation factors are. So I can make all of my dose to the detector calculations or measurements directly on the surface. Now, the last thing, of course, now that I know my attenuation, I need to know the distance. So there's going to be probably 5 to 10 centimeters, maybe somewhere in that range, maybe 8 centimeters, but there's going to be a specific distance from the top of the table to the detector itself, or surface itself. And so you obviously have to do an inverse correction to scale, because you're making a measurement 10 centimeters up. You have to calculate for how much it would change if it was actually your detector was 10 centimeters lower. All right, so I mentioned to you about this RQA5. So at the very beginning, I gave you that little table, that little green table, and it had a bunch of vendors, and it told you how they want you to set up your ion chamber, what KV to use, what filter to use, so that you can calculate the dose of the detector. Now, what if your vendor doesn't tell you? Or what if you just, maybe you have an old system and you don't really have service contracts with your vendor anymore, So you really can't call them, or it would cost you money and you don't want to spend that money. So is there another way to make these measurements? And the answer is to use what's called RQA5. So you saw that in my previous slide. What this is it's an international standard. It was developed by the IEC. And once again, we've talked about them kind of throughout this whole session, the multiple sessions across all the modalities. The IEC defines the standard by which every vendor will build each of their pieces of equipment. So it defines the CT standards, the fluoro standards, of course, the radiographic standards. And one of the things they did is what they said is, we will tell you what the beam quality should be. In other words, the half value layer, to get you the proper beam spectrum to calibrate your system. And now what most people don't say in that Excel spreadsheet, all the vendors, when they're setting up those specific filter combinations with KVs, they're basically establishing an RQA5 like beam spectrum. In fact, if you look here, there can be anywhere between 66 up to 74 kV. It's not a kV particularly specific measurement. The end goal would be a half value layer that's basically 6.8 millimeters of aluminum with plus or minus 0.2 on both sides. So it could be 6.6 or it could all go all the way up to 7. And that would still be okay for RQA5. And it gives you some suggestions on how much filtration you should create to establish this. So as a physicist, you can walk into your room, you can take your ion chamber, you can bring some filters that you would add up by the collimator, and then you got your detector. And the first thing you're going to do is we need to make a measurement to determine if our exposure technique, is an RQA5 certified exposure. So the way you would do that is you take your ion chamber, you place it directly on the center axis, and basically you put it about midway through. Here is a different kind of diagram of the same thing. Here the ion chamber typically is about 127 centimeters, where when you're making a 180 centimeter exposure to the detector. So obviously, if you're going to be doing a tabletop exposure, the sourced image distance is going to be 100 centimeters. And so you take the ratio of that and you just have to move your ion chamber up a little bit. I think it's 70 or so centimeters from the source. Everything I'm about to tell you is written right here. I'm not obviously going to read all this. I just simply cut and paste that here. So if you're watching the recording at home later, you can just pause it and you can read it. Or of course, the PDFs that I'm giving out, if you guys get a copy of that, you can zoom it up and read it to your heart's content. But basically what we're doing here is you got your X-ray tube, you're placing your chamber dead center, and you're going to set it up with a specific distance, like I mentioned. And then you're going to place a variety, you're going to try a couple of different filters. You might start with 0.5 millimeter copper, and you might dial in, say, the middle of that was, say, 70 kV. And then you'll measure your half value layer. And if the half value layer is pretty close, let's say it's 6.6, so it's a little bit low, maybe you could add 1 more millimeter of aluminum and then shoot it again to see if you get closer to 6.8. Or you might move your KV from 70 down to 69 or 70 to 71. You can make a couple of different adjustments. And once you've got that figured out, you just write that down and you know that for the rest of forever on that machine. You don't have to go through this experimental setup. So once you've figured out what you need, you take your filters out, move your ion chamber out of the way, place your detector here, turn on your light, get your field of view set up for the full detector, put your filters back into place, and you pull the trigger. And now you've exposed your detector to an RQA5. And you can also then, once again, cover up your lead and you can place your detector on that and get your dose, your exposure to the detector. So there's multiple ways to get to calibrate your system so that you get the right dose to the detector. And that is very important, as you'll see in a slide that we talk about later. That's very important if you're using automatic exposure controls. So if you put the patient in the field of view, collimate like you know you're supposed to, and you pull the trigger and you let the system pick how many photons it's going to collect before it automatically turns off. Well, it's going to do that based on the dose to the detector exposure factor that you've set up. So if you dial in 2.5 microgray, which is typically what most vendors use, then the system knows to keep exposing until it has summed or integrated to a value of 2.5 microgray. And then it knows to shut off, and you get what supposedly is a good quality, a calibrated image. So the grayscale will be nice and balanced. Now, if you've not set that up, and I've seen this where you go in and you just check the calibration and you look at the dose of the detector and it might be 4, 5, 6 microgray. It's just way, way high. That means for those types of patients, for those systems that are imaging patients, they will get 2, maybe 3 times the amount of radiation dose as another system that's properly calibrated at 2.5 microgray. So it's very important to have that properly set up because the automatic exposure system is based almost exclusively on that number. All right, well, that's great, right? That's great. That's an ion chamber. That's a very specific filter, right? Maybe 21 millimeters of aluminum, so much millimeters of plastic like you see here from the Canon setup. But we're not imaging plastic. We're not imaging aluminum filters. We're imaging patients every day. So how do we know that after we've exposed our patient that they got the right dose so that when you see the image, that you know that that image was properly exposed, that the patient didn't get over or underexposed, and that the system itself isn't going to hide any improper exposures. Like if it was too high, you might get some burnout or clipping in the lungs, as an example. Well, so how do we do this? There is a value called the exposure index. So we talked about that. That's one of the unique exposure metrics or dose metrics in DR and CR. That is not, it's not in fluoro, it's not in all the other, like CT, for example. It's unique to DR and CR. So we need to verify that the EI value that you see at the end of every study, so the technologist acquires an image, let's say a PA chest, and at the bottom of their screen or somewhere on their screen, after they've pulled the trigger and their image is reconstructed, it will tell you an EI value. And then we'll discuss in the next talk how we know that EI value, which EI value is the proper EI value. But what we need to know is to have confidence in that value. So if you see that value, let's say it's 400, and we know that 400 is the number we want, that's the target value, then we're happy. But are we confident that that 400 value is accurate? And so let's talk about how we can make sure these are accurate values. So just a quick reminder, what is EI? EI is the dose to the detector based on segmented anatomy. So what does that mean? Well, in every X-ray system, of course, there's a protocol for all the various different anatomical views that we're trying to image. Here you see a C-spine. Obviously, you can do lateral skulls, you can do knees, you can do chests, abdomens, pelvises, everything under the sun. Well, each view has an anatomical component to it. That's what we're trying to image. So in the C-spine, we're really trying to visualize the vertebrae, of course. We don't really care about the skin line or the soft tissue or the fat. You know, we're looking at its bony anatomy. And so when we tell the system, when we've loaded up the patient and we've clicked on C-spine, we're telling the system that when you calculate the dose of the detector, you should look roughly where a C-spine should be. So it's going to basically calculate and look at the dose and those pixel values of what the system knows or thinks is the C-spine or the bony component of this image. And it will tell you what the dose is behind that anatomy. Now, remember, just a quick refresher, How does the system know where the bone anatomy is versus the soft tissue? Remember, the histograms are unique. A chest histogram will look one way. A C-spine histogram will look a different way. And so the system knows that in that histogram, a certain amount of pixels, in one location, those values, wherever they are in the field of view, the 2D image, those correlate to that type of anatomy, in this case, bony anatomy. So the system can calculate and figure out where the dose is behind this anatomy, which is depicted here using these green pixels. That's just kind of telling you where the system is calculating the EI. So that was kind of a long-winded way to say that EI is not patient dose. EI is very specific dose to the detector as measured in the location of the anatomy of interest. So we can take the EI value and we can calculate one additional metric, called the deviation index. Like I mentioned, there's EI values. There's an EI value for a chest, there's an EI value for a spine, there's an EI value for a wrist, a shoulder, everything. So how do you know which EI value is what? You just there's so many pieces of anatomy we're imaging, so many different protocols. You could probably get lost. Obviously, you could put a lookup table maybe in the wall in the exposure in the technologist area. Or we can calculate something called the deviation index, which is basically a ratio of the exposure index that you collected during that initial exposure. So that's the patient-specific EI. And then we're going to take the ratio of that as a function of the target value. So we're going to tell the system what we expect it to be. So if it was a chest and we expect it to be 400 and we pulled the trigger and it was 400, well, this deviation index, you do the math, obviously it goes to 0. A ratio of 400 to 400 is 1. The log of 1 is always 0. And there you go. You get a deviation index. So now what we're asking the patients or technologists to do is not to memorize a number, but to memorize a scale. 0 to 10, 0 to negative 10, where the cutoff is between good and bad, we'll talk about in the next talk. So how do we check the accuracy of EI? Well, it's very similar to the way we would image or measure the dose of the detector. What we're going to do is we need to establish a specific beam quality. Each vendor will have their unique ones. If you don't know that, then you can use the IEC RQA5. So what you'll do in this example here, I've placed my probes on there. I've set up my source to image distance. I exposed it. I made a couple measurements and realized, okay, I'm good. I've got my RQA5. And now I will take my probes, my ion chamber and my solid state detector, I'll take them off. And then I will put my filter in. And so you obviously won't be able to see the light field, but so before you cover it up, you open your light field up so it covers the entire detector. And then you put the filter over, and then you make an exposure. So nothing in between the beam except for your filter. And you expose the full field of view, the full detector. And when the image is reconstructed, you go in to the post-processing and you turn off all post-processing. You just want a raw, naked image, no post-processing going on. And that will give you an EI value. Dose to the detector based on, say, an RQA5 or whatever the the beam quality factor the vendor asks you to. And you can compare that uniform blank exposure, unprocessed exposure, to what EI should be if you just mathematically calculate it. So here's the equation. This is the IEC, International Accepted Equation to calculate EI. All vendors pretty much today use this equation. 5-10 years ago, every vendor had their own EI approach. And that was a headache. Some call them EI, some call them IDX, some call them S. They all had their own values. So if you have a particularly old system, you might not actually see the value EI. You might, for example, see the value S. It's the same idea, but it's a completely different calculation. So you'll have to look at your manual to know how to calculate S or whatever that factor is. So in an example here, if we are aiming for a 2.5 microgray to the detector and we expose the system and we see that the EI value is 250, well, 2.5 was the exposure to the detector times 100 is 250. So in this case, the EI value of 250 is accurate because we know based on the exposure or the dose to the detector that we should get an EI value of 250. So that's how you can tell. Now, it's not going to always be perfect, right? You might make this exact exposure and it might say 260 or 240. That's okay. You just have to understand what your measurement error is. But we know that if your dose to the detector, your calibrated dose is say 2.5 or 3, whatever your vendor requires, you know what the EI should be under this example where you have nothing in the way except for a filter and you're exposing the full field of view without any filters, any post-processing. All right, so now that we are comfortable, we know that the EI value is accurate on our system. Where do we find this value? And this is more specifically what we would use for when we're collecting large sums of data to do quality control in our hospital, regionally, or something to that effect. Well, every machine that acquires an image will obviously take that image, say it's a 12-bit image, and it will add a bunch of information, all the information. It'll add the KV, the serial number, all of this stuff in just this long text file. This is called the DICOM metadata. And that's why most of these images are 16-bit. The image itself, the actual image, is only about 12-bit. And then there's going to be 2, 3, maybe 4 bits of information that are basically words, document, just text. And in that DICOM metadata, you can find the tag for exposure index. So here I'm showing you, this is literally a picture from my PAC system for, I think it was an abdomen body part exam. Oh, I cut it off, but it was an abdomen, I'm pretty sure. And you can see here, if you go down to DICOM tag 18, 1411, that value will be your exposure index. Or it'll be 1405, one of those two. Now here, the system doesn't actually call it, this vendor doesn't call it exposure index. They still call it relative X-ray exposure. They may name it differently, but if you look at either one of those tags, you will see the value that will be assigned to the DICOM, to the exposure index. Where do you find your target exposure index? And we'll talk about how to set those up in the next talk. But if you're calculating deviation index, right, you have your measured TI and your target TI, EI. And that would be 18, 14, 12. Now, if you look at my photo here, I actually don't have 14, 12. I have 14, 11, it stops. So on this system does not have a target EI programmed into it. And so if I look at the DICOM data, I know that this system cannot calculate DI. I need to add a target EI into the system or I'll never be able to do that. So that's also another way to QC. And then obviously if I have an EI in a target EI set in my system, I will be able to calculate DI. And so you would look at 18, 14, 13, which obviously I don't have. All right, these are the DICOM metadata or the DICOM tags that you will find on IEC standard or compliant X-ray units, which should be basically all of them, especially modern ones. Now, what about actual dose to the detector? Well, if you have that program, if that is collected, that would be tag 40, 0302. And I don't show you that here. And then entrance dose in milligray 408302. So here you have just different values. So if you go and you look in, you pull up an image in PACS and maybe you just right click and you click on DICOM metadata or wherever you would find that in your PACS. That's usually an option somewhere. Then if you look at these tags, you'll know those numbers. And we're going to talk about a little bit later about harvesting all that information for quality control. All right, so we've talked about dose to the detector. We've talked about the value that we would use clinically, which is still kind of an approximate dose to the detector, called exposure index, or EI. And then we've also briefly talked about deviation index on how to calculate it. We'll get into more detail for deviation index next talk. Now, the other metric we had talked about was the incident error curve, the value that would be at the surface of the body, somewhere in that region, if there was a body in between the X-ray beam, between the detector and the tube. So where is this measured? If we're going to make sure, if we're going to collect this data and we're going to harvest and process this data for either DRLs or internal QC, how do we measure this data? How do we use it? So if you're using an ion chamber, so there's no lead backing anywhere in this system, it's just an air equivalent probe, you cannot place it directly on the table. You'll obviously get backscatter. So we typically make these measurements 30 centimeters above the table or wall bucky. And what we'll do is we'll obviously place the ion chamber dead center of this, or the central axis. And we want to do that because we know that there's a heel effect going from anode to cathode side. In other words, there is a side on the cathode side that's more penetrating, and there is this side of the beam over here on the anode side that's less penetrating. It's the heel effect. And so if we make our measurement on either side of those, of the central axis, obviously we would not be able to get as accurate. We wouldn't get as accurate a measurement or calculation. We also would place some kind of lead protector down here just to protect the detector underneath. We talked about backscatter. So we use the air gap to get rid of as much of the backscatter. We also use the lead to prevent backscatter and protect the detector. Now, if you have a digital or solid state detector, this system, if it's got lead backing or some kind of tungsten type metal backing, you can just place this directly on the detector. You don't have to worry about putting it 30 centimeters up. And that's because you will not measure backscatter coming up off of it. All right, how do we know the distance? So we've talked about either 30 centimeters up, or we talk about detector directly on the table. Well, those are places we can find. But I've often talked about source, which is be somewhere here, the focal spot, to image distance to the detector, or source to chamber distance, or source to detector distance. All of these source to something distance. So how do we know where the source is? When you look at an X-ray system, here it's kind of pictured a little twisted and cockeyed. Depending on the vendor, it's usually going to have either some kind of red dot, or it might have kind of a raised bump on it. And these markings tell you where the focal spot would be in spatial context of the anode cathode. So that little dot right there, that is the quote unquote place where the source should be measured. So you take your measuring tape and you'd measure from here to wherever, to the chamber distance, to the tabletop, or to the detector. And that would tell you your distance. So you just have to find that dot. If there is no dot, or if there is no raised bump, you'll have to either talk to your vendor or your service engineer, or look in the technical manuals. There's usually some way to indicate exactly where it is. Okay, so now that we know kind of basically where that value, that incident error curve, that incident error curve is going to be measured either at 30 centimeters off the table or directly on the tabletop. It's that source to chamber distance. We can use that value to calculate entrance skin dose. Now, this equation probably looks somewhat familiar because we talked about it when we did fluoroscopy. The only big difference is in fluoroscopy, there are a couple more correction factors over here, like the correction of the attenuation for the tabletop and the pad and a few other things like that. So what we're going to do here is I'm just going to step you through how to make these calculations by hand. It should be very familiar, so it should be a review. But what we ultimately want to do is we kind of want to have an understanding of about what the dose is to the skin if we're trying to figure out Obviously patient exposure if you actually need to calculate it, but 2, if you're trying to do some quality control and understand roughly what the dose is to the patient. Now, I know skin is not the whole picture, but it's the first thing you can use to make some patient-specific calculations. So here's an example. We're going to use an abdomen radiograph that was acquired at 80 kV, 82 mass. It had a source to image distance of 100 centimeters, so imaged on tabletop, and a source to object distance, in other words, source to the top of the patient, his or her entrance plane of 73 centimeters. We have gone in as a physicist or technologist or whoever in your hospital during our annual measurements or annual Q or testing, and I've made a measurement of air kerma using 100 MAS at 6.7 milligray. And so what I need to do is I need to do a couple of calculations and corrections. First thing I need to do is I need to correct for the fact that this patient was actually imaged at 82, not 100. So I know what air kerma is, 6.7 milligray for 100 mass. So I take 6.7 and I scale it so that it's actually a little different if it was acquired at 82 mass. Oh, I actually did that upside down. That's my fault. The number should be smaller because it's being imaged at a little less, 82. I got that ratio upside down. So this value actually should be a little less. Nonetheless, that's the idea here is you just simply correct for the exposure. I'll make that correction too when I send out my PDFs. Now, the next thing we need to do is we need to scale it based on the distance. So as I mentioned, we know what the source to image detector distance is 100 centimeters. We can actually look that up in our system. Source to detector. In this case, it's in millimeters. So it's actually 1200 millimeters, so 120 centimeters in this example, this image right here. And then we can also calculate what the source to patient distance is. And we can make a couple corrections to scale our number. Now, I wanted to put a little caveat here. When you look at the DICOM data, your vendor may say distance source to patient. And you might think, oh, that's great. I already know it can tell me where the distance is to the patient. But the reality is it has no idea where the patient is. It doesn't know how thick the patient is or thin. That is actually not distance source to patient. It's actually source to tabletop or bucky cover. So it's a slight difference. So in this case, we had to know that our patient, as I mentioned in my previous slide here, that if the source to image distance was 100 centimeters, and then the source, the entrance plane of the patient was 73 centimeters. So we basically know how thick the patient is. So, and now if you don't know how thick the patient is, you can make just the assumption that the patient is roughly 30 centimeters thick. That's the common average thickness of an adult individual. If the person's average size, then you'd say 30. If they were larger, you'd have to make a bigger difference. So maybe they're 50 centimeters or 40 centimeters thick. If they're thin or small, or a pediatric patient, maybe they're thinner. So if you can't make the measurement, you have to make an approximation. So once again, you can come in here and you can do the distance correction. So we made all of our air kerma measurements at 100 centimeters, but the patient is actually thick. And so we had to correct for this distance to the entrance plane. And that gives us now a value of 15.4 milligray. Now, that is still dose to air. We need to remember, make a couple of corrections. We have to correct for backscatter. The idea that when photons come to that point where there is a body, some of those photons will come in, backscatter, and go back out. And so technically the skin is going to be double exposed from photons coming down and some photons or even electrons scattering back up. So that's what this backscatter correction factor takes into account, that skin is getting exposed from both sides. Now this value is going to be somewhere 15 or 30%. We almost always use 30%. So we would say a backscatter factor is 1.3. And then we need to correct the factor that tissue absorbs radiation differently, obviously, than air. And that value correction is 1.06. These are the same correction factors we used in fluoroscopy. So just in case you were keeping track. So we put all of that together, you add those last two correction factors, and you would see here the number. This is the dose to skin. Now, like I said, I made a slight mistake. My mass ratio was flipped. So this number actually should be a little smaller. But nonetheless, you see the steps. So doing those calculations is fine if you need to do it for 1 or 2 patients. But how do you do it if you have 1,000 patients a day in your hospital that are getting x-rays, or 10,000 a month or something? Who knows? Just an amazingly large number. And if you want to do quality control on any number of those, it would be very, very difficult to do that by hand. So what we can do is I'm just going to step you through the process on how I did this. At some level, you can either use it or not. It's really a choice. We'll talk about other ways to do quality control in the next talk too. Most of this information, where is it? Somewhere in here is, hopefully it'll appear. I gave you the citation for a paper I wrote back in 2014. And if not, I'll make sure I get that out. So it goes through all of the detail in that paper. So what we're going to do here is we're going to develop a way to do this using the metadata in the images. So instead of having to do the physical measurements on each patient, all we need to know is some of the information in the image itself, the metadata, KV, MAS, source to image distance, that kind of stuff. And then we can simply from there make all of these calculations, or a computer can do all these calculations, large amounts of them. It's going to require a little bit of input data. We need to do some very basic calculations on all of our systems, or at least all this on one system that's the same for many different. So if you have all Philips, it's pretty much safe. If you do it on one machine, it'll be same for all machines. But if you have a Siemens, a Philips, a Toshiba, or whatever, an Agafa, excuse me, then you're going to have to do these unique measurements on every unique system, unique vendor. So first step, we need to know what air kerma is, that value, that incident air kerma value. This guy, K air. Well, what I did is I went in and I said, I know I can measure air kerma as a function of KVP. And most of my images, most of my patients are exposed with a particular filter combination of 0.1 millimeters of copper plus 1 millimeter of aluminum. Some of them have no added filters. So I basically went in, I just made a bunch of measurements as a function of KV, and I measured air kerma as a function of filter. And then I was able to fit these equations. I was just using basic regression plotting, and I came up with a calculation, or excuse me, an equation. This equation is based on KV and MAS. I obviously had to pick a value. So in my calculations, I used 25 MAS. And I did all my measurements at 100 centimeters source to chamber distance. And so I can easily correct any future exposure. If it was 10 mass, 1 mass, 50 mass, I can obviously scale that by doing the ratio. The nice part is about this equation is when little Johnny goes in and gets exposed, he gets an abdomen, and we look at his metadata, it will tell us what the KV and mass is. So all I have to do is take that number out of the metadata and plug it into my equation, and I know what air kerma is. The metadata will also tell you if it was a filter or no filter, and it may even tell you which filter it was. So here is the tag, the DICOM value, 0018, 7050. It will tell you if there were if filtration was present or not for my system. So, oops, here we go. Here's the equations that I built, I created based on a filter combination of 1 millimeter aluminum plus 0.1 millimeters of copper, and a combination of no filters. an equation for the option of no filter. Oh, there it is. Okay, stop. My thing went crazy. There's right there. That's the publication if you want to look it up. It's in the American Journal of Rankinology, AJR. All right, so now the next factor we need to correct for is backscatter factor. Now, once again, you could just assume 1.3, but actually the truth is backscatter factor will vary somewhat depending on the field of view size. So if it's a real small field of view, you obviously wouldn't get as much backscatter. If it's a large field of view, you're going to get a lot more scatter. And also, it depends on what anatomy you're imaging. So if you're imaging an extremity, you have bone fairly close to the surface. So you're going to have a different scatter factor when you're imaging skin, or you're imaging through skin and muscle, but with bone that's fairly close. You'll just get more scatter up. And conversely, when you image, say, the lungs or the chest, you have a big air pocket. So you're not going to get as much scatter out of your chest or in your lung region as you would, say, an extremity or an imaging, an anatomical region that's bony versus maybe just soft tissue, such as your abdomen. So here you can see the various differences. So once again, I know that I can calculate my backscatter factor based on KV and field of view. And so those are values that I can look up in my metadata. Now, what about patient thickness? Unless you physically measure every patient before they're imaged, you don't know what your patient thickness is. Now, we typically do that at our institution because we're a pediatric center. And we know that we need to scale our protocols based on patient thickness. So that's why we do it. But not every hospital has the ability or time or desire to do that. Most likely desire, because I think you can do it if you want to. It doesn't take a lot of time. So how do we count for patient thickness? We need that information to calculate where to find the entrance surface area. And so what we can do here is when you look in the DICOM metadata, there is no source to skin distance. That's just not part of it. But there is a source to table distance. So we do know where the table is, or the wall bucky cover. And we know the patient's age typically. Most of the time, all protocols are based off of age. So the technologist or the HIS, the HIS system, will bring in from the hospital patient records the patient's age. And so that's how we would pick whichever protocol we're doing. So if we go in and this is something I did, and you can see this in obviously you can see the equations here, but in my paper, it goes into a little bit more detail explaining this. I went out and I measured patient thicknesses. And like I said, we have this for tens of thousands, probably hundreds of thousands of patients by now. We've been doing this for well over a decade. So I know what their basic approximate size is, AP thickness, lateral thickness, as a function of age. It's not perfect, but you can see here for the chest AP or PA, it's mostly linear. Now, it kind of falls apart for me up here in the adult section because we're a pediatric center. I don't do a lot of adults. My guess is if I had more adult data, it would probably continue linearly. You would have to verify that at your center. Now, the abdomen is mostly linear also. And then we know that the head and some of our other extremities, such as the knee, they have more of a logarithmic growth. They grow fast. Those anatomy get up to size relatively fast, and then they don't grow that much afterwards. So knowing these equations, my system can easily, can look up the age of the patient, and it knows the protocol. So let's say it's a chest APPA. It's a 15-year-old kid. It knows what the size is. So now it can scale and correct for that source to entrance distance versus source to image detector. So it can take into account the patient thickness. Now there's the equation, the attenuation correction factors. These are values that are well published. I simply plotted and created a regression fitting function based on data that was already published. So I didn't actually have to measure all this data. And you can also look these values up at AAPM's report 76 if you want. But the nice part is I know what filter it is in the system because it's metadata. Here again, I give you the DICOM tag. And so from that, I know what the tissue correction factor is as a function of half value layer. And so I can use that for chest or for whatever. Let's say we're doing abdomen where we have no additional filter. I can look up the correction value. Now you'll notice that it really doesn't change that much from one filter to no filter, 1.04 versus 1.02. So you can just pick a number and just assume that you can just use that for the rest of forever. You don't really have to worry too much about getting too particular about the where along that curve you're making the measurement. And so what I did is I developed this. I actually created some software, a GUI, a graphical user interface, so I can load thousands of images in and it will calculate out all of my entrance skin dose values. And here I just, as an example, I processed just shy of 4,000 exams. And here's the breakdown of them. And this is kind of what it looks like. So now what you can see here is you can see entrance skin dose as a function of age being along the x-axis. And the blue line is the median value, the mean value. The dashed lines are my first and my third quartile. So the 25th percentile and the 75th percentile of my patient data. Obviously there's maxes and mins, but I didn't show you that. And you can see that for my AP abdomen, lat skull, and APPA chest protocols. Simply just giving you 3 examples. And then I just wanted to prove to you here the data I have was comparable to other publications, other hospitals. And next is our national data repository. This is where all of our DRLs were developed from initially, about a decade or 2 ago. And so that's kind of what these numbers represent. And then just a bunch of other publications. So the values are pretty accurate. What I'm going to show you, and we'll talk a little bit more about this in the next talk when we talk about optimization, is look here. These are all smooth monotonic equations. They're constantly changing, mostly increasing with age, right? This one has this weird bump and then it decreases and then it starts to increase again. So when you look at that compared to all the other curves, you would think that looks abnormal. And so this is one way that I approach to doing my normal quality control to make sure all my protocols on all my machines are accurate. All right, so that was incident error kerma. That's how we calculate that, at least. Next is the CAP and DAP. This is something that we've talked quite extensively about in fluoro, so I'm not going to go into the detail of this. But basically, it's a large area ion chamber. Here is a collimator, the item that sits below the X-ray tube. It's simply detached, so the CAP meter typically sits up here. And so that means every time you make any exposure, you should have a value for DAP or CAP listed somewhere on your screen. And we know that the value is that it takes into account the error kerma as a function of the field of view. And because dose reduces, the amount of photons is reduced by 1 over the distance from the source, but the area changes as you also get farther away from the source. It gets bigger and bigger by the square root, by the power of 2. So these two values basically correct for each other. Photon count is lower here than it is here, but the area is smaller here than it is here. And so the nice thing about CAP or DAP that is displayed on your system is that it is the same from the source to the point of entrance. Obviously, CAP is going to be different below that because of attenuation characteristics of the patient and scatter effects from the patient. But for that region from here to the entrance point, the CAP and DAP is the same. So how do we make sure that cap or DAP is accurate? Well, the simplest way to do that is if you have a DAP or cap meter. It's just a very large ion chamber. Actually, it's it is a diode. It's a system that has a lot of different small individual diodes that are scattered throughout. And so it's able to measure error curve as a function of field of view, as you can see here. So you can set it up on any type of geometry. You can place some PMMA blocks below it to simulate patient anatomy. You can do whatever you want. If you don't have a unique cap or DAP probe, then what you do is you're going to use your typical ion chamber or solid state detector and a lead ruler. The lead ruler, of course, is going to be used to measure the field of view at the point where we're going to place our solid state detector or ion chamber. So we make an exposure on the screen. We can get the measurements of the field of view and we calculate the total area. And then we take that ruler away and we put our ion chamber or our solid state detector here. And then we make a measurement and we have our error curve. So we multiply the two values, incident error curve times field of view size, you get cap or DAP. So in summary, we've reviewed the common dose metrics for DR and CR and how they're measured and how we validate them. And this is just a reminder. I know this was a very technical publication talk, but when it comes to calculating or creating DRLs, you have to know that those values are correct. And ultimately, DRLs aside, you want to know that you're getting the right dose to the detector, the right dose to the patient, so you get the right image quality, so our radiologists can do their job. So we reviewed error curve at the detector, and we talked about how we absolutely need to eliminate backscatter from those measurements, so it's true and accurate. We talked about incident error curve and how in this system, where this is a measurement that does not include backscatter. And so we actually, if you want to do skin dose, you have to include backscatter. We talked about cap or DAP, which is the same from the source to the point where the patient would be. And then we, of course, talked about EI and DI and how these can be used for patient quality control, which we will go into greater detail in the next talk. So thank you. I know, like I said, that was a very technical talk. And so those are the dose metrics. I don't know how many questions will come from that, but we can always get into more of the more clinical side of that when we get into the next talk. So Tanya?
Sure, yes. Thank you so much, Sam. There is a lot of formula and calculations on your talk. There is a question from the chat box. Which DICOM track is represent? Oh, hold on. Okay, so which DICOM track is represented the FOV because I found only row and column. So how can we find out the FOV on the DICOM track?
So yeah, every vendor. So the DICOM structure is the same for every vendor. It depends on what each vendor how they actually fill that. So that's the one caveat to this. Some may actually tell you what the area is, the field of view size. Others might tell you the row size and the column size. Now you can make some calculations because it'll tell you what the row is and the column is for the matrix, and it would maybe even tell you what the pixel distance is. So you have to do the calculation. So you know how many pixels you have in X, how many pixels in Y you have, and you know their spacing, and you can do the calculations. That's probably more work than you really want to. You can also take the cap or the DAP value because you know what that is. You know what error curve is, and you know what cap is. Well, if you divide the two, that'll tell you what the field of view is. So there's a couple of different ways to kind of look at that if the field of view value is not directly listed in the header. And so unfortunately, and then if all of that is not, if all of that is difficult to come by for you, you can do a very rough approximation. You know, for a chest, you can go in, let's say you have 10 patients, you can go in, you collimate the light field to their body, and you can just kind of do a quick measurement using a measuring tape, and you would just get a rough idea. But for the most part, for adults, as an example, we're going to have basically the same chest field of view. I mean, there are going to be taller people, they're going to be shorter people, they're going to be thinner, and they're going to be thicker people. But it's all going to be not too different. And so if you get just one number and you use that for all your patients, it's not going to be perfectly accurate, but it's better than nothing. It's better than nothing. But ideally, if you look inside your DICOM data, there should be some value that will tell you the field of view dimensions.
Okay. Okay, sounds good. So next question is about, so it seems like we are able to extract the value of the interest to calculate the patient exposure from DICOM tag combined with the using data from meta-analysis in case that the output measurement and patient thickness are not able to perform. This is really useful method. However, how much of the uncertainty from this calculation method among the different manufacturers, exposure technique, or diversity of the patient characteristic?
Yeah, so that is true. The accuracy of this method is going to be limited by your measurement error. And that is always true. If you go back, if it will go back, probably the biggest error in all of the measurement or the calculations is this approximation of size. You can just see it relatively by my error bars, right? And so I don't know exactly what the patient's size is that got imaged in that moment. But based on that person's age, the population average would range. So in this case, this 15-year-old would average somewhere around a 27 centimeter, about a 19 to 27 centimeter change spread in the APPA thickness. So it's not perfect. That if they're an average patient, they're going to be somewhere in that range. If they're abnormal, they may be even outside of that. So the value is not, so that's probably the biggest error when you look at this overall equation right here. That said, what I guess the utility of this is, and you'll see this in the next talk. I don't think I have a plot. Yeah, I don't have a plot here. Is what happens when you now take all of your data, all of this data, and you look at it as a function of all of the entrance skin doses as a function of the AP abdomen or skull, and you're going to get a range. That is for sure. You'll get dashed values from minimum, or in this case, first quartile to third quartile. But what you're looking for here is a response function, a graph, that is, for all intents and purposes, logical. This is something that you've calculated. You see it's monotonically growing with age. And I'll talk to you about this in the next talk, how this right here is an abnormality. This was actually how I found that for the APPA protocols in our patients that were being imaged basically under 6 years old, the values, the KV value, the dose to the detector was incorrect. And I did not know that based on just some of the other values that we were getting out, the EI numbers, because the system thought it was accurate, but it was actually the calibration factor that needed to be adjusted. And so if this number right here is slightly higher, slightly lower for some patients, that's okay. But when you look at the spread of the population, as I mentioned, these values in that one plot, there's about 4,000 patients there. And so we're looking at kind of like a population average, or not average, but distribution. So obviously, I mean, the best thing you can do is get as accurate as you can in your measurements. So you can get real accurate when you're making these measurements right here, your air kerma values. I don't show you my error bars here because they're basically zero. They're basically non-existent. I can be very, very accurate with these measurements. And therefore this equation right here, this first value I put into it, can be really, really accurate. So do your best to be as accurate as you can for the ones you can control. Age is, that's just one of those things. Unless you physically measure every one of your patients that walks through the door. And if you can do that, then this approximation right here, not that one, this one right here, this one, you can get rid of that measurement error, and your overall skin dose for your population will be actually pretty accurate.
I think that's going to be the tough job to do the measurement on every patient for us.
Yeah. And it's like I said, if you really need to know what a specific patient dose is, I'll give you an example. About a month ago, we had a young lady come through our clinic. She didn't realize she was pregnant, and she had a series of exams, CT, X-ray, this, that. After all of that, and the radiologists were looking at their images, unfortunately, they found out she was pregnant. So in that example, I needed to know very specifically what her dose was, so I could calculate, obviously, the dose of the fetus. This approach right here that I talked about is probably not an accurate approach because it's just an approximation. In this case, I actually went in and I was able to look at her images. I was able to make physical measurements. I knew exactly how thick she was in her, down in her pelvic area, in her lower abdomen area. I knew exactly what the KV, the MA was. I knew all that. And so I could go back to the first way I did this, remember? I did it by hand. I actually did the calculation by hand, which was a lot more accurate. In this case, the example where I built an equation or a software to do it, it's mostly just for quality control. It's not patient specific. It's population averages.
Yeah, it's like for the specific questions or like a specific patient that we need the accurate dose for further treatment or evaluation.
Yep. But for this type of approach, what we're doing here, the whole reason we're meeting is we're talking about quality control for all intents and purposes. Yes. We're trying to find metrics that we can use that are accurate, that we can collect to eventually establish for diagnostic reference levels. And obviously you guys have already done a lot. You have your entrance surface, air kerma. We're going to talk about that in the next talk, in the next talk I have. And so you guys will actually do something somewhat similar to this, not as detailed, but you've gone through and you've collected a lot of this data. And then this is a way we can use that data for other hospitals that haven't had a chance or the ability to collect this data. And then they can try to scale their values based on those numbers. So, when you look at it as a quality control approach, then the slight variation in measurements, the slight variation in accuracy, I think is okay. But that's, of course, my opinion.
Yeah. So the last questions from me, based on this lecture, is a lot of the technical stuff, measurement for the physicist. For me as a radiologist, how can I contribute, or what is the key message from this talk that I can integrate to my practice or improve the process?
Sure. So radiologists will not be physically making these measurements. Radiologists probably don't care or even know what the dose is to the detector. That's something we rely on the physicist or the technologist, whoever they have in their hospital, to make sure that the machine is properly calibrated. But what the radiologist has as a tool is the EI, the exposure index, or the DI, the deviation index. So every time a new patient shows up in front of them in the reading room, they can look at that number and they will know if this patient was properly exposed. And so we'll actually talk about that in the next talk. And how we educate our radiologists is, obviously up to each hospital there. Not every radiologist even looks at those numbers. They're too busy looking for pneumonia for COVID, right? When they're looking at a chest radiograph, they're not necessarily worrying too much about the EI number at the bottom of their screen. In fact, some hospitals in their hanging protocols, they don't even list the EI. They might list the KV and the MA or whatnot, but they might not even anywhere on the screen show you the EI number. And that's something that, you know, as I lecture here in the US, I always advocate that the radiologists ask their PACS team, their IT group, they can easily turn that on. It's just another number that shows up on your screen.
You mean like on the screen that we have images that we can have that number maybe on the corner close to like a KV or MA. Okay. Yeah.
And then that's just something that the radiologist in time will get used to seeing. And EI numbers are hard because you'd have to memorize a table of values. But a DI number, as we'll explain on the next talk, is actually a lot easier, because if you have a value, if you know 0, DI of 0 is perfectly accurate. That's a bullseye. You know, if you're playing darts, that's a bullseye. And so if you look at it and you say DI of 1, you're like, okay, hey, I feel comfortable with that. This patient was maybe just a little overexposed, but not wildly. But now if you get a DI of 10 or 15, you as a radiologist, well, you may look at that image and say, there's probably something wrong here, because that person got exposed by that much, just way too much radiation. In fact, if they took their mouse and they probably windowed and leveled, they would probably see clipping, for example, in the chest, in the lung field. And so that's how those numbers will, I think, be used clinically. But we'll talk about that in the next talk.
Sure. Thank you. That sounds good to me, because at least I know what I should look for, and we can ask the PACS team to add that number. So after we know what are we looking for, we can keep looking on that number and maybe improve the quality of the images and give the feedback. Yep.
All right. So do you see my next talk?
Yes.
Perfect.
I saw it.
So going on, so building off of what we were just talking about, why do we do this? Let's just take a moment and ask ourselves this question. Well, DR and CR is the most frequently used modality, right? A radiologist may look at, or a hospital may have, 100 CT scans a day, or I don't know, a couple hundred MR, depending on how many scanners they have. But they're going to look at easily many hundred, maybe 1,000 X-rays, just planar radiographic imaging. So it is the most frequently used imaging modality throughout the entire world. And luckily, it's one of the lowest radiation dose modalities. So the question is, wait a minute, if it's a low dose radiation modality, why are we worrying so much? It's the idea that we use it so often that even if it's just a small amount of radiation, it adds up to the whole population. And so when you look at making some changes, if you make a change to, say, CT, which is a high dose protocol modality, that's going to make a big impact, but it's actually only affecting a very small percentage of your population. Now, if you make a small change in DRCR, now once again, that's a small number, so it's a small change, but it's making a big impact to a large group of people. So when you just look at it kind of in a mathematical way, even though it's a low dose modality, it still makes a very big difference when you talk about the whole population of, say, Thailand or the US when it comes to medical dose. The other reason is oftentimes, DR, CR imaging, it's of course it's two-dimensional, right? So it's all of our anatomy compressed into one plane. And so it can be hard at times to read through that. If you're looking at the lungs, well, you're looking through ribs, you're looking through mediastinum for the heart, you're looking through the scapula, you're looking through all this anatomy that's compressed into one image. And if the dose is not quite right, if it's a little too low, it's going to be extra noisy. So I'll have all the anatomical information all in one, and then it's being covered up by noise. And so the point here is they're already difficult enough to read. We got to make sure that there's as good a quality as possible so the radiologists are comfortable getting their diagnostic or doing their diagnosis. And the second reason is let me step back. Film imaging in radiography is mostly gone away. I would assume that in most hospitals, and probably in Thailand, I can speak for the US. There are basically no hospitals that use film here in the US. So there may be a few in Thailand, I don't know. But for the most part, those days are gone. And digital imaging masks poorly optimized dosimetry. In other words, you can get a fairly good image. It must be the next slide. I'll have some images in the next one I'll show you. But for the most part, if you overexpose a patient by 2 times or maybe even 3 times the dose, the image will still look the same. If you underexpose the patient by a little bit, the image will be a little grainy, but for the most part, it'll be okay. So digital imaging is actually fairly forgiving. And that's because the digital detectors have a linear response. And so given the ability for anyone to use their mouse to window and level, they're able to overcome some of these inherent deficiencies that they're seeing. And so image quality in digital images do not correlate with patient exposure. So if the image looks really good, it might be properly exposed or incredibly overexposed. You really don't know. And the example here is if an exposure is less than 50% ideal, then you'll see a little bit of noise. So you can be off by, approximately 50% too low, and the image would be mostly okay. The exposure can be over 200%, over 200% greater than it should be before you start to lose contrast. And so you can see here that if you underexpose just a little bit, you start to feel the pain, right? The noise creeps in a little quicker. But if you overexpose, you really, really have to overexpose that patient, turn that knob all the way up before you can visually see that you've overexposed the patient. And because of this, we tend to see what's called dose creep. In other words, no technologist wants to have the radiologist call them up and say, this image was bad, I cannot read it. Call the patient back, re-image it. No technologist wants to hear that. And so therefore, it's so much easier to say, we'll just make it a little hotter, just a little bit more radiation. Then I know the image will have no noise in it. We're okay. I won't get yelled at. The image quality will be sufficient for the radiologist. But over time, people tend to keep turning that knob up, keep increasing the image quality. And so what happens, because there isn't that physical cue like film, when you overexposed a patient in film, it ruined the image. And so because we don't have that visual cue, it can accidentally creep up over time. And this is the example I was trying to show you a moment ago. So when you look at film on your left, underexposed, obviously was very white, overexposed was very black. And remember how we talked about when you look at the histogram, the exposure level would shift. If it's ideal, it'd be somewhere in the center. Underexposed, the histogram, the pixel values will be shifted left, more towards the white side. Or if it's overexposed, there'll be a lot more black pixels, dark pixels, and they'll be shifted to the right. And then, of course, the shape of that. Remember, the shape is always specific to the anatomy. But in digital, look at that. Underexposed. Now, you may be able to see from your screen that this is obviously noisy, right? It's a little less noisy. Excuse me, more noisy. This image, I would hope you would think that's a pretty good quality chest radiograph. And then this one right here, overexposed, I would think you would probably say, as a radiologist, I will still read that image. That image still looks pretty good. But the reality is this image right here, had it been imaged on film, would look horrible because you burned out the lungs. So we have to be able to figure out a way to optimize our images using, these dose metrics that we've talked about. And as Tanya asked, what can we use so that the end user, the technologist, and the radiologist know that they've acquired the image properly, the dose is correct, therefore the image quality will be appropriate. So we talked about error curve at the detector. We calibrate this, we establish this so we get proper auto exposure control, AEC control performance on each system. And then we talked about the incident error curve, which is the value that is more typical to a patient or a population, depending on how you're calculating it. These are the values we compare to published doses. We're going to compare it to the national DRLs that Thailand, for example, has built or measured and developed. We can use our CAP or DAP, and then we have the EI and DI, which we're going to focus on. All right, so why worry about the radiation dose calculation to the detector? Well, we know, as I kind of verbally said this in the last talk, by the time the photons pass through the patient, pass through the grid, the table, the grid, to get to the detector, it is altogether very small. 1/100th of the entrance dose, 0.02 milligray at the exit, compared to, say, 2 milligray at the entrance skin level. So what we need to do is set up the proper dose to the detector, and you want to do this for all the X-ray units in your hospital. You need to make sure that if one patient goes into room 1, they're going to be exposed similar if they go into room 2, 3, etc. So what we need to do is calculate the dose per mass for all of our X-ray rooms. And we do this as a way to know that the auto exposure control is the same. Now, obviously, we want to know that the patients are getting the same radiation dose if they go from one room to the next. But in a bigger picture reason, we're doing this so that the image quality will be the same from room 1 to room 2 to room 3, etc. Here in the US, our standard is plus or minus 20%. So if you go in and you say you image under RQA 5 standards, so you have 6.8 millimeters of aluminum, half value layer, and you measure it at, say, 100 centimeters, source to 100 chamber distance of 100 centimeters, and you do, let's say, 25 mass, you'll get a value, a dose. I don't know, let's say it's 10. Well, let's just say it's 25 milligray. So 25 milligray divided by 25 mass is 1 milligray per mass. And now I go and do that exact same thing in the next room. And if it's within plus or minus 20%, I'm happy. Obviously, I'd like it to be better. And then I go to the next room, the next room, the next room. And if they're all basically that same ratio, I feel comfortable knowing that my systems are all performing at the same level. Therefore, the same size patient on every machine should get the same dose, and the image quality on every one of those machines should be the same. So now we're going to use the EI to verify that in real time, every time a patient is exposed, they're examined, they get their exam, and then the images show up in PACS. And Tanya and all her radiologist friends have talked to the PACS people, and now they see EI at the bottom corner somewhere on their screen, and they're going to look at that value. Now, like I said, EI is a great number, but EI for a C-spine is different than the EI of a chest, of a lateral skull, et cetera, et cetera, et cetera. So what we're going to do is we're going to actually calculate, we're going to use this value to calculate DI. I recommend this just because it's so much easier to remember. And I hope that all of your systems would allow you to do this. Definitely the newer systems. DI and EI, DI has been around for at least a decade now. EI has been around for longer. So at the minimum, I know all your systems will be able to show EI. In the best case scenario, they can show DI. But to get DI, the key here is the EI target. So we talked about quite extensively in the last talk how we make sure EI itself is accurate on the machine. So we're just assuming that's already done. We are assuming at this point it is accurate. So what is the target value per protocol? Most systems, especially the newer ones, they may already come with vendor-specific preloaded target EI values, or TEI. And the way you can do the way they do this typically is they'll just image a bunch of phantoms. They'll pick, oh, that one looks overly exposed. That one looks good. Okay, I like this value, so I know the EI of this value, and that becomes the target EI. Now, you can do the exact same thing using your own phantoms, and that would allow you to figure out if you like the target values that the vendor provides for you. Ultimately, the target value you select needs to make the radiologist happy. Some radiologists, for whatever reason, may want to see an image that looks a little bit more this way, or they may want to see it look a little more that way. And so you're going to work with probably your lead imaging, your lead radiologist for all the various different areas, maybe your thorax people, your abdomen people, your MSK people. So it's going to take a little bit of work initially to set up your target EI values. And maybe if you don't have a lot of physics support and a lot of lead technologists, or your technologists don't have a lot of freedom to work on this with like a radiologist, then maybe your major academic centers have to do this. They establish it and then they can share that with other local hospitals. And, you know, a population, say in central Bangkok versus northern versus southern, you know, your population distribution will be slightly different. But locally, hopefully it won't be too different. The variation won't be too bad. So the target EI at one hospital is probably going to be the same as the target EI at another. So you can do it individually for every hospital, or you can do it for, okay, maybe like a region or a group, a larger group of clinics. So this is an example of how I did it. Now, I would argue that it's basically the same here in the US as it is in Thailand, as it is in any other place in the world. That is, when you look at the exposure index distribution, then what you will see is, this is basically a Gaussian curve. You know, it's got a kind of a normal distribution. There's obviously a central peak here. There's the mode. So the median is going to be somewhere in this region, right around here. And that value is, in this case, about 420, 450 EI value. Obviously, it's got some lows and we've got some highs. Now, this is some, I talked to you about building that software. This is that software interface, that GUI. Here you can see the date, December 16th. So let me just talk a little bit about what you see here to make my point. So what it does is the system loads all of the different machines. It loads all of the exams that were acquired on that machine. So obviously we do a lot of different looks in radiography. It actually even lists all the the users. And so I can run reports based on each user or technologist if I wanted to. Mostly I want to look at this as a function of exams. So in this case, I have PA lateral, chest, PA lateral listed. And when I run this report, it looks at and I can tell it what my upper limit. I will pass or fail based on a deviation index of +1 and -2. That's just a random number. You could pick a completely different number if you wanted. And then any patient exam that falls outside of that range will be listed here. Now, this is just how I do my quality control. I've obviously blacked out the patient MRNs. But the point I want to make here is this is old data. December 6, 2016, May 2017. Look at the peak here. This peak is basically 420. This peak, 420. So even though I had back in December of 2016, I had a larger skew of patients that got underexposed. And by May, as we worked with the technology to get everything a little bit better, you can see there was a lot better usage of the system, of this particular scanner. And there were very few patients that were under and very few that were overexposed based on my criteria. You can still see that the value in the center basically was the same. That is a very good candidate for target EI. So I could use the value that the vendor gave me. In this particular vendor, they say a chest PA and lateral should be somewhere in the 400. In our case, when I worked with the radiologist and I got the image to look the way they wanted it by setting the KV and the MA and all of that, the auto exposure control, all of that, it actually turned out to be about 420. And so that was my target. And you can see how it's basically the same. Now, there is always a distribution. There's always going to be a variation. We're not always getting a value exactly at the target value, EI. But we want to get it within a range. And so that's how we can use it to calculate the DI. All right. Now, I explained that. So when we establish the target EI value, we have to obviously create it for all the different types of anatomy. And so you can run your reports, you will do your you can use your dose software, your dose reporting software such as Radiometrics, and you can collect a report of all the chest protocols and the knee protocols and stuff and look at EI. Or if you don't have that software yet, you can simply just run reports. You can talk to your PACS people, and I'm sure they could run a report, because obviously they can look at all of the images in the PACS. They got hundreds of thousands of PACS, and they could probably run a report that looks at the DICOM header. And even if they didn't do all those crazy calculations I talked about previously, if they at least pulled the one number, the EI value, the EI value and the protocol, so if is it a knee, a head, or whatever, then you can start to create these types of histograms like I showed. So those are the two most important things: the EI value and the body part. So we set that up, and when you look at the distribution, you might see, well, there's the median or there's the mode right there at the dead center. And so 420. Now you go and you look at the images. You pull them up on PACS, and you get an example of, 10, 20 patients that were all imaged with an EI of 420. And you look at them, you get a radiologist to look at them with you, and they say, yeah, I like this. I think this is good. Now you might also have them look at some that are a little lower, maybe a little higher, and they might say, well, this all looks fine. This all looks fine. So you just look at that distribution and say, okay, I'm going to start that value off as my target index, my target EI value. You do it for all the different protocols, and you create that TEI for, you create it for all of the protocols. But one thing that you kind of want to do is you want a higher level value. In other words, there's chest, right? You don't want to get too in the weeds. You can find a target in EI value for chest, but if you have a TEI for AP chest, for PA chest, for lateral chest, for supine chest, for decubitus, prone, you can if you want, but that's a lot of target values, and it gets to be more cumbersome to maintain all of those values. When it's all said and done with, remember, the histogram, when you acquire an image of the chest, the histogram will mostly look the same, almost always, for across all patient sizes, both genders. It's always going to have kind of basic same peaks and values. As it shifts left to right, that tells you if it's over or underexposed. Now, if the patient was prone, supine, standing, APPA, all of that, the histogram is going to look a little different. It might shift just a hair there, here and there, but for the most part, it's going to look the same. So what I'm trying to say is don't overdo it. A target index, target EI value for chest, for maybe arms or legs or extremities in general, abdomen, pelvis, that's probably the high level that you need. And we use that to calculate DI. So setting up, now that we can calculate DI, the question was, as a radiologist, I'm looking at my screen and I'm being attentive. I'm awesome like Tanya. And I look at it and I says, ooh, I got a DI of 0. Well, I know DI of 0 is awesome. But what happens when I get a DI of 1, 2, 5, -4, 7? How do I understand that? So basically a decade ago, when we originally calculated and came up with the idea of DI, the physicists arbitrarily said plus or minus 3 is the threshold for good and bad. Everything above and below a DI of negative or positive 3 should have the image. You should reacquire the image. You should re-expose the patient. And what ended up happening was, from almost day one, people were imaging and they would see an EI value of 3, maybe 4. And they would look at the image and they say, this looks great. It looks fine. I see no reason to re-expose this. But yet I was just told if the DI is over 3, I should re-expose. And so from day one, everyone started to question those arbitrary limits. So in a another group got together, and I was part of that group, and we looked at it for 2 or 3 years. And in 2018, we published our results. And basically, we looked at tens of thousands of exams across all of the US, and we wanted to know what the distribution of DI values was at all hospitals, or most hospitals, of course. And what you see here is just that result. DI all the way out to plus or minus 10. And what we also did is we took those images and we not all of them. No radiologist would sign on for that, but we looked at hundreds of images, thousands actually, not tens of thousands, but thousands of images. The radiologist, we looked at them and we did it for across all of the DI values. And then they basically scored them saying good, bad, or ugly. And what we found out was that basically within that plus or minus 10 DI, most of the time, the radiologists were okay with those images. The image quality looked fine. There wasn't really any clipping there, at the higher level. And even though it was a lot more noisy at a minus 10 DI versus a 2, it was still okay. They could still get what they needed for their calculation, for their read. So here you can just see some plots on the right-hand side, a couple of different, each hospital is denoted by a different letter. I don't remember which one was my hospital, but basically you can see here that the dashed lines were plus or minus 3. That was the original value that we said was good. Obviously 0 was perfect. And then what you see here is the bar, you have the whisker plots. So the median value is shown as the bar. And then you got the first quartile at the bottom of the box, third quartile, and then you got your minimums and your maximum. And just looking at this, just the overall spread of it, besides Hospital E, Hospital E was the only one that had a median of actually no, Hospital F was the only one that was close to having a median value of 0. For everyone else, I mean, these guys, some of these median values were over the plus or minus 3, but yet that's how they were imaging every day. Now, would it be nice if we got everyone right down the middle? Probably, and using quality control techniques and maybe a small team of physicists, radiologists, technologists, and PACS people, your IT folks, we can work to kind of streamline that and try to get that all down the middle. But the point here is we found out that yes, you can actually image with a DI value that was greater than plus or minus 3. In fact, you could probably get even higher. So what we did in our publication is we recommended that you start looking for quality control problems after plus or minus 2 standard deviations from your mean. So obviously every hospital, as you can see here, has their own means and median values. And you know what the standard deviation 1 and second standard deviations are. So you can do this for your own hospital. Now, the image may not need to be reacquired, but the image should be flagged for review. And so if anything's over this once again, an arbitrary threshold of plus or minus 2 standard deviations, it's a place, just a recommendation, a place for you as a hospital to start looking at why that image was imaged, why that patient was imaged such that they were outside of plus or minus 2 standard deviations from your hospital's norm or median. So let me give you an example from my hospital. And what ended up happening is we were looking at our chest APPA. So this is that weird little hump that you saw in my patients. In my, we looked at intrinsic skin dose as a function of age. Well, this is a plot of, so the first here on the left is deviation index and frequency. So this is just a normal histogram plot. So the vast majority of my patients that were getting or undergoing an APPA, the vast majority had a DI of 1, which is pretty good. And then a little bit higher 2, and then somewhere between 0 and 3. And that was basically my first standard deviation. 86% of my patients, or the patients at my hospital, fell within that plus or minus 3. I just use that as a common way to look at that. Not that I said that was the right or wrong way. That's just the way I looked at it. So most values that were outside of this range were for a very specific protocol, patients under 6 years. So now I plotted this data as a function of their age and the deviation index. So once again, this is just data that I can take from the DICOM header. I know what their age is. If the technologist types that in, or if the computer pulls down, the RIS system pulls down the patient's medical record and puts the age in for you, which they pretty much always do nowadays, you can make this plot just like I can make this plot. And here you can see, it's a scatter plot. So our older patients, and we don't do a lot of them because we're a pediatric center, but we do some. The vast majority of my patients, you can see here from 25 down to basically 6 right here. That was just a big clump of them all right there around deviation index of 1, which is this dashed line right here. And then here's my plus or minus 3, the solid red bars. Vast majority. Now, there was always an outlier. There's always an outlier for everyone, right? Someone didn't get positioned right. Maybe someone has scoli, so they can't align properly. The system's going to calculate a weird DI if the patient just can't be positioned normal. And so abnormal patients will cause abnormal values, but that's okay. We look at some of these people, some of these exams, and you immediately see that they're contorted because they're maybe because of scoli, and you immediately go, okay, I know what's wrong with, just move on. We know that the system can't do any better than that. Now, if it's a patient that got normal looking patient, but their lung fields got totally burned out because the technologist somehow did something weird and it's just a really high dose, well, then that's an education point where we can go back and try to educate. But in this case, you can see here, when I looked at the data under 6, the preponderance of mine, I had a very large, so a lot of them were fine, but there was this chunk right here that were being overexposed, and there was this chunk down here, there's really teeny little young kids, they were getting way underexposed. So I knew I needed to go through the process of quality control on those. Now, I'm going to talk about that in a second. What do we do in the moment, though? Patient just got exposed. The technologist is sitting in their work area, the console area. They pulled the trigger and they looked at the display. If you have a system that will immediately display DI, that's a good thing. And I would highly recommend you turn that feature on, because then they can immediately ask themselves, is this good? Is this above or below my 2 standard deviations? Now, how do they know what that is? Unless they're great and they like to memorize numbers, they probably won't know. So you'll need to put a chart in their room, in the control booth. And that control booth will be for, chest, abdomen, pelvis, all of the major protocols with the target indices, target EI values. You will just simply say, this is my target. This is the acceptable DI range. This is less than 2 standard deviations, might be a DI of -8. And so they would look at their screen and say, oh, I got a -9. I am outside of that -2. What should I do? Well, this is kind of the workflow that at least we recommended. You don't necessarily have to do it, but we recommended this in our publication, where that person would talk to either their supervisor or the lead quality control technologist, if you have one. And they're going to just look at it. And if they feel it's diagnostic and it's acceptable, then they would just send the images to PACS, but then they would flag it, mark it down as something that they should review. If you have a monthly QI monthly group that gets together, or a quarterly, however you look at your rejected images, your rejected films, however you do that, you would just mark this and review it. Now, if the two of you have put your heads together and go, I don't know, it looks pretty noisy. If you're not sure, that's when you pick up the phone, and if your radiologists are okay with this, you would call them. The radiologist would then pull the image up in PACS. They'd make a very quick look at it and say, yeah, that's okay. And obviously they're going to push it off the side and they'll keep going, doing their own thing. And eventually that image will get pulled, that patient will get pulled up later for review. But if the radiologist says on first blush, it looks okay, then it goes to PACS and on, mark for QI. If they say, no, this doesn't look good, just initially, I don't really think I could read this, then obviously you would re-image the patient. And in a somewhat similar way, if the value was higher than 2 standard deviations, so let's assume that it's the upper level, the upper standard deviation is 9. So the lower was -8 and the upper is say 9. And it's just written on a piece of paper in their control area. In this case, they call their supervisor again and they look at it. Now over 2 standard deviations, it means it's going to be highly overexposed. So what you're looking for now is evidence of burnout and clipping saturation. If there is evidence of this, and if you try to reprocess it like we talked about last week, and you still see the clipping of saturation, then what you need to do is reacquire the image. But if you look at it and maybe there is, but when you change the lookup table, it kind of clears up and the grayscale still looks okay, then you can send it to PACS, obviously mark it for QI, and you review it later at a later time. And then always, if you are in doubt, consult a radiologist, etc. So the only real big difference here is if there is potential burnout, then you can maybe try to adjust it. All right, so that was the approach for setting up your EI targets and your DI. So how do you use that then for internal quality control? We talked about, it looks like, oh, forgive me. One of my slides it's either out of order or I accidentally deleted it. So I'm sorry. I meant to talk a little bit about the results of this. So hopefully that slide will pop back up. So if we see it again, we might have to do a small little detour. But moving on now to incident error kerma. So this is the idea of setting up a value now that we can use for a diagnostic reference level. And so this is what you guys used in Thailand. You used actually not the incident error kerma, you did the entrance surface error kerma. So incident error kerma, remember, does not include backscatter. The entrance surface error kerma does include backscatter. And then if you took it one more step further and calculated the skin dose, you would need to add a couple more correction factors. So entrance error kerma is the value that we're going to typically use to calculate our national DRLs. So how do we know that this is proper? What do we need to do to make sure this is properly calibrated? It's a good value that we're submitting so that the value can be averaged and then, of course, redistributed as a national DRL. First thing you need to do, these are some generic pre-step optimizations, is you need to make sure there's a standardized KV for select exams. So chest exams, abdomen, pelvis, you just need to make sure that we have standardized KVs. This will allow you to compare these values between hospitals with similar equipment and protocols. In other words, try to set your techniques, your acquisition techniques, so that they're fairly similar, at least inside your hospital, but definitely regionally, that would be ideal because then the values are more the same across the board. Obviously, we need to calibrate the AEC system, as we talked about quite extensively. This allows for the MAS to be the same mostly for every body part. The KV is a value you have to change physically. You have to select that. But for all your AEC protocols, the system will select the MAS if it's properly calibrated. And then, of course, the second option in all this, you let the system do it, or you used fixed techniques. So you can look up charts you can set or place lookup charts for mass and KV in the control booth, and then they just know to do this. We, for example, do something somewhat similar to this where we use patient size as a metric. So every patient that walks in the door, we use calipers. If they're doing, say, a lateral chest, we'll measure their lateral chest. If they're doing APPA, we'll measure, of course, their anterior-posterior dimension. And then the system will have electronic charts where they just look at the size and they click on the value on the screen, and it automatically sets the right KV and it sets the right sensitivity and all that so that we know that we'll get the right MAS on the output. So how do you set up these exposure charts, or how do you verify them? Well, we've talked quite a bit about using different types of phantoms. We talked about using plastic, these PMMA blocks. They're great. They're not patients, of course, but they're very adjustable. I can add a block or take away a block. So I can change the overall thickness of my quote unquote patient so I can get a rough idea of how the exposure, the technique factors will change with size. I already talked quite a bit in a couple of talks, several talks ago. I gave you the breakdown of how you could set up an abdomen for a 5-year-old, a 25-year-old, etc. How many block thicknesses you would need. So I'm not going to go back over that. You can always go back to that talk. But the point here is using a phantom gives you the ability to really play with your techniques. Whereas obviously you can't do that with patients, and obviously you shouldn't do that. And if you have the anthropomorphic type phantoms, well, you just need a lot of them, and that can be very expensive. All right, so we talked about making those correction factors to entrance skin dose. And so we talked about doing this calculation by hand, or we can do it by, that technique I shared. And this was the slide I meant to show you a couple of slides ago. This idea that here you go, we see the age, the patient age as a function of deviation index. And you got your plus or minus 2 standard deviations, you got your plus or minus 3 DI, and then we got your mean. Now, if I take this data and I actually plot it a little bit differently, if I take and I plot it as a function of deviation index and entrance skin dose, because I have that approach that I discussed last time, here you can see that distribution of the lateral. That looks normal. There are, of course, some in cases where the patient being underexposed, but if you look at the AP and PA, that does not look like a normal distribution. There is this big chunk of patients that are being overexposed right here, and you can see the relative effect of it on their entrance skin dose. What would be a normal exposure, somewhere below 0.2 down to your typical less than 0.1, 0.07, etc., 0.05 for a normal chest. Here you can see this protocol was horribly overexposing our patients. And so by knowing that, I was able to go back through and make some corrections. So when you plotted it as a function of age and entrance exposure, so not deviation in entrance exposure, but age and entrance exposure, that's how I identified which protocol was not going properly, made the corrections, and then you can see this is what it's supposed to look like, at least for my hospital. We always put a little bit more dose on our teeniest, tiniest patient, and that is because they have the teeniest, tiniest anatomy. And we absolutely want to be able to see those teeny, tiny structures. Unfortunately, you just need a little bit more radiation dose, but that's okay. So this little tail up, this little point that goes up a little higher, that's expected, but we don't have this weird hump right in the middle. My data is nice and monotonic now. It does increase, as it should, with size. And so by making that correction to that one protocol, now everything, now 95% of my patient exams are within DI of plus or minus 3. And, there's the patient doses. The point here I'm trying to make is all I have to do is tell my radiologist to think of a number, plus or minus 3, plus or minus 4, whatever it is that you establish as a normal range in your patients. And then that's all Tanya has to think. She doesn't have to think of an EI of 400 for chest, an EI of 300 for an arm, an EI of 200 for an abdomen. She just needs to know that it was within plus or minus 3. And then she then would obviously, with education, and the same for all radiologists, with education, they would understand if they get a DI that's a little higher, if they feel comfortable with their read, they do their read. But if it's over that number, maybe they flag it and they ask for the technologists and the physicists to review that as part of their QI process. Okay, so moving on, we talked about skin dose. Skin is only one organ in our entire body. When it comes to fluoroscopy and radiography, it's basically the only organ that we calculate the dose for because it's the easiest one. When it comes to calculating all the other organ doses in our body, it's very difficult because in radiography, unlike CT, we're not actually imaging the whole circumference of the body. And, the field of view can be actually quite coned. And so you may only be getting part of the liver and only part of the, the heart. Or you might, if you're doing an abdomen, you might only get the bottom part of the heart, for example. The chest, of course, you only get the top part of the liver lobe, upper liver lobe. And so when it comes to actually calculating organ doses, it's not that big a deal in X-ray, in my personal opinion. And that's why you actually don't find many publications that talk about organ doses in X-ray or fluoroscopy. In fact, I was looking through a bunch of publications and I had to go back pretty far. In 1998, this is a really good publication, if you're ever interested in reading it, where they used Monte Carlo to simulate the dose to the various different organs. And then they came up with correction factors. And so if you know what the skin dose is, then you can correct for various, applying the different correction values, you can calculate the dose to all the different organs, if you're interested in knowing that. And obviously, in this graph right here, I believe was for a chest, which was interesting because you look at the organ that probably got the highest dose is the adrenals. And that was just because, they're sitting right there on top of the kidneys and they're just right at the bottom of the field. At the bottom of the field, remember the Hill effect is the most exposed, the most penetrating. And it's got the greatest intensity of photons versus the upper part right here, where it's the best resolution. So therefore, the organs down here are getting a hair bit more radiation. And of course, adrenals are teeny, so they just dose as a function of mass, they get the most. Lungs, obviously the next, because you're imaging the chest, the thorax, biggest organ in the whole compartment. Interestingly enough, you look at breast. Here we are, all the way down here. One of the lower dosed. You're thinking to yourself, well, for a female, breast anatomy can be a larger portion of the overall thorax. But because it's a PA, and that's typical setup for most chests, by the time you go from posterior to anterior to the point where you start exposing the breast anatomy, remember, we lose about 1/100th of the dose. We go from, say, a 0.2 milligray to a 0.2 milligray exposure on the output. So, or situating the patient as just kind of a classic example of being able to do dose sparing to relatively sensitive tissue. Breasts are relatively sensitive to radiation. And by doing a PA exposure, you are actually doing a very good job of reducing dose to that organ. So what are some rules of thumb? You can, if you want, come up with all these correction factors to calculate organ doses. I don't really think it's that necessary. But if you do know the skin dose, a good rule of thumb is that about every 4 to 5 centimeters deep into the body, you lose half of your photons. So you lose half your dose, roughly speaking. So if you know the dose to the skin, and we did one calculation as an example, let's say it's roughly 20 milligray. Well, you go down 4 centimeters or 5, now it's 10. Go down 4 or 5 more centimeters. Now it's 5, 2.5, 1.25. You get the idea here. You're losing half of it every 4 to 5 centimeters. So you could start to do some approximations of the depth of these organs, and you can start to do averages. But what you see here is, let's take your liver as an example. The liver is going to take up a large part of that anterior to posterior geometry. Therefore, the part of the liver that's the closest to the entrance is going to get a lot, and the part at the bottom is going to get very little. And so you're taking some kind of average over that area, maybe the midpoint, can give you a rough estimate of what the liver dose is. But it's highly heterogeneous. So unless you really need to know what the abdomen doses are, I would say it's probably not worth your effort to go through and calculate it. The only time it's probably necessary to do some type of organ dose calculation, it would be more of a do the fetus or conceptus depth. And so if you had, as an example, a pregnant patient that comes through and you want to know what the dose was to the fetus, well, Conceptus depth dose is typically assumed to be 6 centimeters. Now I get it, that depends on, the stage of pregnancy, depends on how big the mother is, etc. But in general, from the skin surface deep, we typically assume the fetus is roughly about 6 centimeters deep. Fetal dose to a lateral projection is assumed to be about 5% of entrance skin dose. Fetal dose from a chest x-ray, obviously you're imaging up here, your lower field of view margin is at the, basically the abdomen, the liver area. So you have 10, 20 centimeters before you get down to the pelvic area, down to the kind of the uterus area. So now the doses are only about 1 to 2% of entrance skin dose. And here you can just see some other values that I took from a publication. So really, in my opinion, fetal doses are probably one of the few ones that you need to do an actual true organ dose calculation, quote unquote organ. So how do we optimize the most common dose metrics in DR and CR? We talked about all of these. Oh, there we go. We talked about air kerma. We talked about auto exposure controls, incident air kermas, cap DAP. We talked about good ways to set up EI. We talked about how to set up your target EI. We talked about, of course, what it means to do a DI calculation and what are some numbers that you can establish, or at least an approach that you can use to establish DI values that you can then share with your radiologists, etc. So now let's talk about diagnostic reference levels. Diagnostic reference levels, of course, will give every imaging clinic a chance to optimize their system based on the national values. You don't necessarily have to go through all of these steps that we've talked about. If you don't have the physicist, if you don't have the capacity to do these calculations, you can at least rely upon the DRLs provided by the government, or by the national institutions, I should say. Now, what you need to do, so you got the Thai data, which I'm going to show in the next slide, and they've established it for what, these 7 protocols. And then for most DRLs, you're just going to pick your 7 most common or the most typical type protocol, and they're going to provide you some numbers. So you need to do basic effort to understand what your value is at that entrance surface air kerma. So you'll take your air kerma values, your incident air kerma values, and you'll need to do some very basic backscatter correction calculations for these groups. Now, maybe you don't have the software, maybe you don't even have the ion chambers. You'll have to figure out a way to get those values, or at least common values. But at least once you get those values, you can maybe look at a small sampling, 10, 20 patients in each of these categories, just to get a rough idea, which will be a way to compare yourself for the DRLs. Ideally, you'd want to be doing a lot more, 20, 50 per category if you're looking at it manually. And if you can do it by software, obviously you want to do hundreds of thousands. And what you'll do is you'll make all those corrections, as I mentioned, and you can now compare your values to the national DRLs that have been established in Thailand. So by now, you all know the DRL is the 75th percentile. It's the 3rd quartile. So you'll have your means and your median values that you can look at. But what you're hoping is that your values will fall underneath. Your median value will be less than this value, the P75 or the DRL. So if you have a chest PA, its median value is 0.3, then you're at or below the national DRL. So that's good. Maybe room for optimization, but hey, you're below the national DRL. If it's a little less, then you're doing fine. If it's a little more, then it's a potential goal for you to try to reduce the dose in that. And then you can go back to the various different approaches that we talked about on how to identify which protocols, if there are sub protocols that are maybe over performing. So we already talked about this several weeks ago. I know this is something that is an active work, is an active project where your film screen doses are actually quite lower well, in some categories, than your digital doses, where the reality is digital doses really should be the lowest because they're the most flexible because of that linear response. You can actually go pretty low and still get really good image quality. And so I'm interested to see in the next version in the next couple of years as you collect more data to see if all of your quality control, your quality, your approach to review and to diagnose and to improve will make a significant change to these values here, and see that the film screen values will probably hold constant because you've been doing those for decades, but these values will probably come down. But overall, compared to the IAEA values, as you guys have listed here, you're doing great. In some categories, you're lower. Some categories, you're a little higher. But for the most part, I think you guys are really doing great. So my one comment to you as I was reviewing these numbers was, if you hand this data out to all of these hospitals, they need to understand how you calculated your entrance surface air kerma. So where did you do that? Now, you provided the typical size patient, 60 kilos, but what you probably need to also do is, what is that typical thickness? 30 centimeters? So that means when hospital A in northern Thailand, they have their chest PA, and they need to know what that incident air kerma value is multiplied by backscatter so they can calculate their ESAK. But they need to know where to either make that measurement or to look that value up. And so it's probably going to be, 30 centimeters from the table or wall bucky, or so many centimeters from the source to some point in air. And so you may have already provided that value, but I just didn't see that in your table. So that's something that I would recommend, that as you send that out, that's a number, that's a value that they can use to baseline all their measurements from. So you need a distance from the source where the DRL entrance surface was calculated, or a distance from the table or the wall bucky, just a point so they can orient it. And it's going to be an average value, right? Because there's a lot of 60 kilo patients that might be bigger, and a lot that'll be less than that. But that's okay. It's just one value that they can make their calculations so that they can scale their numbers to compare them to the national DRL. All right, so I am over time. My apologies. So we've already talked about those summary topics quite a bit, so I'll just skip over that. So radiographic doses are inherently low. I think we've already discussed that, but they are the most common examination type. So we can do so much good by spending a little bit of effort trying to make sure we are consistent or consistently good at imaging and radiography. All right, well, thank you.
Thank you so much, Sam. And I think right now the Ministry of Public Health is on the second round for the survey on the DR and CR dose. After we have the first survey in 2017, so this is this year they're planning for the CR and DR, if I remember correctly. Yeah. So I think there is one question from the chat box, and you already answered that. So the question is about the manufacturer exposure index. Should we use that one, or should we do based on our populations? Because there is a different target between adult and pediatric population. And I think you already answered that things that we can have our own exposure index.
Obviously the best place to start is what you've got. So if it comes pre-populated on your system, that's great. You've got something to work with. And then as you then set out, you have to understand everything I've talked about setting up all of these quality control programs. They've taken me years and years to develop. And so it's not one of those things where you're going to go out and you're going to do every one of your protocols in a month. What you do is you start with the top 7, kind of like Thailand has done. Maybe chest and abdomen are your 2 most common ones. And so you look at the EI values that are distributed in your system. You look at the target EI value that either the vendor provides you or maybe a regional hospital provides you. And then you start to ask yourself, looking at that number, say 420 for the chest, have your radiologist look at it. And if they like that, you're good. And then you just keep going with it. And you can make slight changes. And I think the one thing I probably should have put in my slides was, will these values always be the same? And the answer is no. Just like a DRL. With time, every time you do another survey for DRL, one would hope they are actually slowly changing, maybe decreasing. Eventually you might decrease to a point after 2 or 3 cycles and they just won't change again because you've just lowered the dose as low as it needs to go. But for the most part, people come and go. Radiologists aren't the same in every hospital. And so there may come a point where one radiologist leaves and a new one comes in, and that person says, I don't like the way this looks. So you have to be kind of flexible with how you set these target values up. But once you've established something that looks really good and it feels good for the group of radiologists, then you just run with that. And maybe every couple of years you revisit that and make sure everyone's still happy. Could we lower the dose? Do we keep the dose where it is? Are we missing anything, et cetera? And obviously new technology comes out. These machines are getting so much better at handling noise such that we could probably reduce our target EI a little bit compared to maybe 5 years ago. And the images will look perfectly fine. The noise won't have any more noise. And that just gives us the opportunity to be a little bit better when we image our patients.
You just answered the thing that I'm gonna ask next, because my understanding is like when we start with the exposure index, it's like the first step, and then we do some processing or calculation to get the deviation index for the radiologist or end user to understand the image quality, to say that we need to bring the patient back to re-image or not. And then the next step on that part, we can do the dose adjustment, right? To maybe like lower the radiation dose that we give to the patient. Is that correct? In terms of like a step?
And the one thing I would say to all of that is, remember that it's not ever based on one patient. And so that's why we collect all of these. So if a patient specifically was imaged and they're lower than or above, as an example, the 2 standard deviation DI, you as a hospital have to decide if you're comfortable with 2 standard deviations or only 1 or something in between. Let's assume 2 for now. If the value falls outside of that, in that moment, you make sure the images are sufficient for the radiologist. If they are, the patient goes away, the radiologist does their read and they write their report, or they dictate their report. And then that patient gets listed and gets put in a bucket that we will review. And we keep collecting in this bucket. And at some point, monthly, quarterly, annually, whatever we do, we look at all of them. And if we see that there's a trend, this particular protocol is consistently having issues, then we fix that protocol. If it's just 1 patient or 2 patients, like I said, there's always going to be just something weird, right? The patient that can't position properly, or maybe the radiologist was just having a bad day and didn't like that noise, right? Radiologists never have bad days, right? And so if it's only just 1 or 2 patients, we don't want to go and change protocols based on just a small sample. And that's why we do need to collect this and over time review it. And when you get a sufficiently large population of issues, then yes, change.
Yeah. And right now for the DI deviation index, you recommend plus and minus 3, or can we go up to plus and minus 10 when we look on that things?
Historically, it was plus or minus 3. But what we found out was that +4, +5 was still okay. We found it was generally okay all the way out to 10, plus or minus 10.
Okay.
But that's why what we say is because it really depends on the radiologist. It really depends on your hospital. And so look at your distribution. And then I would say, look at 1 standard deviation, look at 2 standard deviations. As a publication, just as a group of scientists, we got together and said, 2 plus or minus 2 standard deviations is actually a pretty big jump. That's all the way out there at the, 8, 9, 10 DEI value. And so we should probably start to look at images and start to ask ourselves, why are we so far away from the median? But if you set whatever you set your value at, just know that the value, that the image itself is probably going to be okay. like I said, plus or minus 10, we were seeing it was okay. It really was. They're digital. Obviously if it's film, it's not going to be a different, it's completely different thing. But if it's digital, the images are going to be pretty much okay. So start if you want. Just tomorrow, you can start thinking plus or minus 5, just if you want to pick that number. And then you start to realize, oh, I'm collecting a lot of I'm getting a lot of images in my QI pile. And then you review them the first month or the first quarter, and you realize, oh yeah, like all of those were okay. So then maybe you can say, let's move that out a little bit. Let's make that plus or minus 7. And then you start to realize now there's fewer and fewer. Because remember, one standard deviation is 67% of your population, right?
Yes.
2 standard deviations is 95%. So what you're saying is at 2 standard deviations, 95% of the people that walk through your hospital, the images will never be flagged for quality control. Never. The radiologist will never call the technologist will never call the radiologist, and hopefully the radiologist will never get upset. And so, but we're talking about maybe 5%. And that's the whole reason we chose the 2 standard deviation. We figure 5% of a hospital that does, let's say they do 100,000 patients a year, right? So what is that? That's 5,000 patients a year that you would have to review. That's kind of a lot, actually, if you think about it. So you probably don't want to set yours too tight of a value, if that makes sense.
That makes sense.
Yeah, that's the reason why we chose 2 standard deviations.
That makes sense. And I'm going to start looking on that DI number when I read the study from Monday. So thank you for telling me that. Yeah, at least it's a good practice for me.
Yeah, and just looking at that, and you may, as a radiologist, calibrate yourself, depending on how many plain films you read a day. But you might start to realize, oh, wait a minute, that's plus or minus 3, plus or minus 3. I'm starting to think I don't like plus or minus 3. And that just might be for you. And then you can start to talk with your overall QI group and say, hey, I just noticed, and it's going to take a while because you're not probably looking at always the same chest radiographs. You're going to look at knees, arms, legs. I don't know. You might look at a variety. But my point here, well, obviously you're looking at the head, but but my point here is unless you're consistently seeing the same, if you're consistently seeing the same, then you as a user will probably start to realize what your preference is. Now, you're one person, so you have to work with the group, but being able to bring attention to this, like, hey, I feel awkward. There's something not right about the DI value for this lateral head. That's roughly around a negative DI of 4. And then that's a way for the group to go back and start looking at it too. So 2 different ways. Radiologists can come and talk to them, or they will go to the radiologist and say, hey, can you look at these images?
Agreed. Yeah. So next one is, to my understanding, the DI can be effective indicator for QC QA in case that the TEI is optimal.
Yes. Right? And yes, she's right on the nose on this. If your target values are not appropriate, I mean, what does DI mean? A DI is just the ratio of the value for the protocol for the patient in that moment to the target. So if your target of the chest, now I showed you my value, it was about 420. And if you, for whatever reason, actually set it at 200, well, that means the vast majority of your images are going to have a really high DI number. They're all going to be, 7, 8, 9. And when you look at your histogram of DI, it's going to be highly skewed to the high end. And you'll be like, okay, something doesn't look right. So when you just do your statistics and you look at a nice Gaussian, if you see a nice Gaussian curve, then you probably know the value right in the middle is okay, or it's a good place to start. But if you look at your distribution and it's highly skewed to one way, one left or right, then you've probably not set the right target value, if that makes sense.
I see. Yep. Okay, so that makes sense. And the last comment is about if we pay more attention to the TEI, because the TEI is reflects the deviation index. So which means we need to pay attention on those things.
So yeah, definitely as a physicist talking to other physicists, That's the number that I can change that makes the biggest difference, obviously, right? So I know that my dose to the detector is appropriate because I do that calculation. And I know that my EI value is correct because I do that calculation. Then the next thing I can do is make sure my target EI is correct, because then my DI calculations are accurate. So those are the three things I do as a physicist every year. I'm constantly just double checking those.
Yep. Okay, so thank you so much, Sam, for teaching us a very practical things to understand the physics, and we can apply it in our daily practice. And you can teach me to start looking on the physics number and things and pay more attention on those things. So thank you so much for always giving us excellent lectures. And
thank
you. And as usual, so after these lectures, we're going to send a link for evaluation, and please complete the evaluation by Thursday midnight. So Friday, you will get the CME certificates, and on Friday, you will get the link for the next week lectures. And next 2 weeks, we're almost done. We have 3 more weeks to go. So next 2 weeks, we are going to talk about the mammogram. And on the last week, we're going to talk about it's like a wrap-up session. So if anyone has any questions, particular questions that you want Dr. Brady to comment, so please send us an email, or you can also put it in the evaluation form on what questions or what else you want. We want Sam to explain or give more detail on that part. Because right now we have one question about the gonad shields in children. Do we still need to do it or not? So maybe we can put that things on the last session, for maybe the basic stuff, for the gonad shield or thyroid shields in children. Should we still do that thing or not?
Since that was actually specific to radiography, if you want, I can address that next week. I can talk for maybe 10 minutes about that and tell you kind of, how we do it and what are the rationale of using it or not using it.
Yeah, because in the past, we always put a gonad shield in every patient, but right now, seems like we don't need to do that anymore, but we still do it just in case or something. So what is a rationale behind those things?
Sure.
Yep.
I will talk about that first thing next week.
Okay, sure. Thank you so much, Sam. And we will see you again next week.
All right. Thank you.
Yeah, thank you. Sawadee. So thank you so much. And we also want to thank our sponsor, Bayer, Philips, and GE to support this educational course. Thank you so much, and see everyone next week. Thank you. Bye-bye.